Hello everyone, I'm Dr. Rohit. I'm going to discuss today on the Mercy trial published in the Journal of the American Medical Association. This is a recently published trial, um, which is called as the continuous versus intermittent meropenem administration in critically ill patients with sepsis. The Mercy randomized controlled clinical trial. The beta-lactam antibiotics are the most widely used antibacterial drugs. If you see any ICU, approx 60 to 70% of all IV antimicrobial prescriptions consist of beta-lactam antibiotics. And the pharmacokinetics are time dependent, and their efficacy is related to the amount of time they spend above the MIC, which usually approx the recommendations are that the time above MIC should be 60 to 70% above the time above MIC compared to the total amount of time in 24 hours. So, in prolonged periods, yeah, if the MIC remains below the minimum inhibitory concentration, if the concentrations remain, then you decrease the efficacy and you potentially allow some of the bacterial population to resume growth. And this bacterial population that resumes growth has got a resistant phenotype. So this is the reason and the background that some of the pharmacokinetic studies suggested that the prolongation of administration of beta-lactam antibiotics can increase the serum levels. They can maximize the time above the MIC, and they can potentially improve the efficacy of beta-lactam antibiotics. But these are all pharmacokinetic studies. Clinical studies included RCTs and systematic reviews and meta-analysis. The systematic reviews and meta-analysis showed that continuous or extended administration may decrease mortality in patients with sepsis. But the randomized control trials showed um, equivocal results. Some of them were positive and some of them were negative. And there was a lot of heterogeneity in the patient population amongst the patients who were included in these randomized control trials. Even the surviving sepsis campaign guidelines suggest prolonged administration over intermittent administration of beta-lactam antibiotics, including meropenem, and this has been clubbed as a weak recommendation with moderate quality of evidence in the surviving sepsis campaign guidelines. So to date, there has been no suitably powered double-blinded RCT focusing on meropenem that has been conducted in critically ill patients with sepsis. And thus, the continuous infusion versus intermittent administration of meropenem in critically ill patients, the MERCY randomized control trial was conducted to answer this question. So the PICO statement for this trial was patients who were critically ill, adults with sepsis. The intervention was continuous administration, which was a 3 gram of meropenem infusion over 24 hours. The intermittent administration was the control group, which included 1 gram of meropenem over 30 to 60 minutes every 8 hours. And the outcome was a composite outcome of all-cause mortality and emergence of resistant bacteria at day 28. So if you note here, the two groups which were there, one was the continuous administration and the other was the intermittent administration. So whatever literature has been available till now, the intermittent administration has been usually been defined as something which is given less than 1 hour infusion, whereas the continuous administration, which has also been labeled as extended infusion or prolonged administration, is usually given something over 1 hour, and in most ICUs, it is at around 3 hours. Some of them give it over continuous infusions, continuous over 8 hours, three doses, which is 24 hours long, continuous infusions. But the crux remains that continuous administration is something which is prolonged or an extended infusion, which is above 1 hour's duration of infusion. But for this trial, the continuous infusion was continued of 3 gram of meropenem over the complete 24 hours. So the trial design was a multi-center double-blinded randomized trial, which was across 31 ICUs in 26 hospitals in 4 countries, which included Croatia, Italy, Kazakhstan, and Russia. The patient's inclusion criteria were such that they were first initially screened for eligibility, and all patients who were prescribed meropenem according to the clinician's judgment were screened for eligibility. And as soon as the screening for eligibility happened, the criteria was seen whether they could meet the inclusion criteria. They had to be at least 18 years of age. They needed new antibiotic treatment with meropenem as judged by the clinician. They were admitted in the ICU and they had presence of sepsis or septic shock, which was defined as below. Do note that the sepsis definitions that they included also was a combination of previous and current sepsis definitions. So there was a systemic inflammatory response syndrome also included in the definition of sepsis as per their inclusion criteria. And the septic shock was all as usual in the current sepsis 3 definitions. And the patient was also needed to be able to express informed consent by some of his kith or kin who were able to give consent for the patient. The exclusion criteria for the patients included obviously the expressed informed consent and also if they had got the study drug or other carbapenem such as imipenem both as a bolus or as a continuous infusion. Then they were excluded from the trial. It had only had to. So the trial included patients who only were started on a new antibiotic meropenem for the first time, and if they had a known allergy or intolerance to the drug, then they were excluded. And if they had a very low chance of survival, which was SAPS-2 score of more than 65, then also they were excluded. If they had concomitant some amount of immunosuppression in terms of a acquired immunodeficiency syndrome, or if they had immunosuppressant or long-term corticosteroid therapy, they were also excluded from this trial. So the randomization was web-based central randomization with the use of computer-generated permuted block sequences. This is pretty standard, is used in most of the randomized trials. The randomization was stratified according to the study center. The patients, physicians, and study investigators were blinded to the treatment allocation, but the pharmacists and the ICU trial nurses were aware of the treatment allocation, but in no way were they involved in any sort of data collection or analysis. Data collection was again performed by trained personnel who did not participate in any of the clinical activities for the patient, and they were blinded to the group allocation as well. So it was a well-blinded trial, double-blinded trial. The initiation of study happened when all patients who were assessed for eligibility, they were taken into the trial. Once the initiation, the patients were taken into the trial, they were given a 1 gram bolus of meropenem immediately after the clinician decision to use the carbapenem, and immediately before and the use of that meropenem, if already there was no cultures sent, then cultures had to be sent. But if there was a culture sent in the preceding 48 hours, then though no repeat cultures were sent. And the type of cultures, the respiratory cultures included a distal protected samples, and which was a bronchoalveolar lavage with a protected specimen brush. 3 samples of blood cultures were obtained with at least 1 sample not drawn from an indwelling vascular catheter. That is, at least 1 peripheral sample had to be sent amongst the 3 samples of blood cultures. So this was the type of infusion that was given. The bolus group included symbolizes the intermittent group. So in the intermittent group, patients were receiving infusion of meropenem, which was for less than 1 hour, and that was titrated as per the creatinine clearance estimated by the Cockcroft formula, as mentioned here. If you can see here, this is different types of standardizations of their creatinine which was done. And the continuous infusion group, similarly, again, it was continued over 24 hours. And according to the creatinine, again, the amount of drug that had to be given for 24 hours was calculated. So there were a few circumstances where there could be a change in the amount of the study drug apart from the renal from the creatinine clearance, and this was based on sometimes on physician judgment, where the total amount of drug would be doubled. This was one of the drawbacks of this study, actually, where the physician judgment was used as as being able physician judgment. If the physician felt, then they could double the dose of the meropenem. And this was in circumstances such as if by looking at the culture results, or culture results where there was a high MIC of the bacteria, or if there was a suspected meningitis, then in those cases the physician could double the dose as well. And the stopping of the study drug, meropenem, was also primarily by the physician judgment. And although there were several general rules which were applied, and which were given by the investigators to the physicians, it was ultimately the judgment of the physician whether to stop the meropenem after giving for a certain duration of time. So, as a general rule, some of the rules that were applied were for patients with microbiologically confirmed diagnosis. For Pseudomonas aeruginosa, 15 days of treatment was given. For any pathogen with an MIC between 1 and 2, at least 15 days of treatment. For pathogens for MICs less than 1, approximately 8 to 10 days of treatment. And for patients in whom there was without a microbiologically confirmed diagnosis, they suggested to continue treatment for at least 8 days, and to consider stopping antibiotics when these criteria were met. So the primary and secondary outcomes, primary outcome was a measure of a composite outcome. Basically, it was mortality at day 28 and a combination of mortality at day 28 and emergence of new resistant bacteria at day 28. The secondary outcomes were death from any cause at day 90, the antibiotic-free days assessed at day 28 after randomization, ICU-free days at day 28, and a cumulative SOFA-free point from randomization to day 28. A SOFA free point is basically the number of points of SOFA, 24 minus the SOFA score of the patient, where you get the number of SOFA free points. And then when you accumulate it, when you add it up to day 28, that is the cumulative SOFA free point, which the authors have defined. So the statistical analysis was pretty standard. They hypothesized that the primary outcome of composite outcome would occur in about 52% of patients in the intermittent group, and there would be a 12% reduction, absolute risk reduction in the continuous group. So the continuous group would be having approximately 40% as the composite primary outcome. So considering this difference, the sample size of 300 patients per group would be required to achieve would be required to achieve a greater than 80% power to detect such a difference at an alpha level of 0.05. They did plan interim analysis at 150, 300, and 450 patients, and the composite primary outcome was analyzed using the two-tailed chi-square test based on an intention to treat principle. So for continuous variables with a non-parametric distribution, data was expressed as median and interquartile ranges, and the Mann-Whitney test was used. For variables with a normal distribution, data was expressed as means and standard deviations, and the t-test was used to compare outcomes. And even a time to event analysis of death was also performed with the hazard ratios and corresponding confidence, 95% confidence intervals were also calculated. And data was stored electronically and analyzed using the Stata software, and a two-sided p-values of less than 0.05 was used as the statistical significant threshold. So if you see the results, this result shows the first consort diagram, which has shown us that there was approx 900 patients who were screened for eligibility, out of which approx 300 were excluded. And the most common reason for exclusion was that they had already received meropenem or other carbapenem antibiotics. So there was a high number of patients in their ICUs who were receiving meropenem at the time that they were screened for whether whether they would be able to be eligible for the trial. So after all these exclusions and for eligibility, 600 patients were randomized, out of which 303 in the continuous group and 304 in the intermittent group. Finally, approx 279 patients met the protocol standards, and 280 met protocol standards in the intermittent group. And this was because few of them, some of the exclusions according to the protocols, was that the most common was that they did not have a blood culture obtained before the drug initiation. This also shows us that There are patients in whom the blood cultures were not initiated before the drug administration. So these were patients who would have had negative blood cultures because of the antibiotic going in before the cultures were drawn. And ultimately, there were 303 who were in the primary analysis, and 297 in the per protocol analysis in the continuous group, and 304 in the primary analysis, and 298 included in the per protocol analysis in the intermittent group. So these were the baseline characteristics of the patients. If you see here, they were pretty old age, 65 years of age in both groups. They were well balanced in both groups. All the baseline characteristics were well matched. But if you see the age, it was very high, approx 65 years in both groups. They did also include a certain amount of data on race and ethnicity, which was determined by the treating clinician. If you see, mostly it was whites who were 95% of patients. Patients did have certain comorbidities such as diabetic chronic kidney disease, approximately 20% patients in both groups. And one of the interesting things was the number of patients receiving antibiotic therapy within 3 months before the patients were randomized into this trial. And this was pretty high at approximately 65%. So you can very well imagine the number of patients who were receiving some antibiotic, who had received some antibiotic within the past 3 months of this ICU admission and randomization. A lot of patients were also sick in terms of having because they were having a tracheostomy or a tracheal tube. So approximately 75% patients were either mechanically ventilated, 60% patients were having septic shock. So this was also a lot of patients who were very sick. And the most common sites of infection were respiratory tract and gastrointestinal tract. The clinical severity scores were also pretty high. The SOFA score was approx 9 in both groups. And this is the amount of time that each patient had spent in the hospital to the time the patient was randomized was approximately 9 days. So approx 9 days of hospital stay in both groups, where before which the meropenem the meropenem was thought to be started by the ICU physician. So this was the primary baseline characteristics for both the groups. So if you see the amount of studied drug doses and the use of other antibiotics, concurrent antibiotics along with the meropenem, which was used, if you see here, if the number of isolates, a number of patients whose isolates were not susceptible to carbapenem antibiotics, it was approx 30% in 30 to 35% in both the groups. So you can as well imagine the amount of patients who are having carbapenem resistance in their ICUs, which is approximately 30% in both groups. The initial meropenem dose, which was used, was dosed according to the guidelines which I mentioned earlier, according to the guidance which the investigators have given to the clinicians. But few of those patients also received a high dose of meropenem, which is 6 gram per day, which is 2 grams TDS. Approx 10% of the patients who received this high dose, this could have been due to two reasons, which we already discussed. One was if it was a meningitic dose of meropenem, suspected meningitis, or if the clinician felt that the bacteria had a very high MIC and thus needed a higher dose of meropenem so that it could overcome the MIC. So the meropenem dose which was given was obviously approx 3. This was very natural to have 3 because 3 was what the protocol dictated as well. And the number of dose changes that was done, approx 10% in both the groups. Meropenem dosing changes were done. Approx 10% changes were done. And the duration of meropenem that both the groups received were approx 11 days in both groups. So once they started giving meropenem, it was continued up to approximately 11 days. That was the median time for which it was continued. And the overall dose was approximately around 20 to 24 grams in both the groups. So there were some interesting results, which was also there in further antibiotics which were given along with meropenem. If you see here, a concurrent antibiotic approx was given in around 75% of cases. So along with meropenem, if a tigecycline or a polymyxin B, something which was added along with the meropenem, it was given in around 75% of the cases. Or even a vancomycin, if the glycopeptides were used, it was approximately around 30% of the cases. So if you see here, these are the different antibiotic classes which was given as concurrent administration along with the meropenem. And if you see what microbiological characteristics that these organisms, that the cultures had grown, it was usually the big four, which is Klebsiella, Pseudomonas, E. coli, and the Acinetobacter. Little bit of Enterobacter also was there. In the gram positive, it was usually 50% cases which were having some sort of a cons, that is a Coagulus negative staphylococci, and a few cases, 15% cases of Staph aureus as well. And there was polymicrobial infections, gram-negative infection, two infections in the same patient, which was approx 20%, and gram-negative and positive, which was also approx 20% of cases. So coming to the primary and the secondary outcomes, if you see here, primary outcome was a composite of all-cause mortality and also an emergence of drug-resistant bacteria at day 28. In the continuous administration group and intermittent administration group was approximately the same. It was 47 and 49 respectively, and the difference was not statistically significant as well. And if you see the individual components of the primary outcome, also the all-cause mortality at day 28 was 30% and approx 30% in both the groups. And this was also not statistically significant. And the emergence of drug-resistant bacteria was also similar in both the groups, and this was also not statistically significant. So the primary outcome was not different between the two groups, and it was also not statistically significant. The secondary outcomes also did not show any difference between the two groups. The 90-day mortality, the time alive and free from antibiotics at day 28, the alive and free from ICU at day 28 as well. Some of the post-hoc exploratory outcomes also did not show much difference, and none of them was statistically significant as well. And when you analyze the Kaplan-Meier curves for the composite primary outcome and secondary outcome of probability of mortality at day 28, if you see here, both the lines are very close to each other, and there is not much difference between the two groups with respect to the composite primary outcome or to the secondary outcome in terms of the duration of time after randomization. So both the groups were almost similar in terms of the Kaplan-Meier analysis as well. So, to discuss further on what the results were and what to take home with these results, and there was no significant difference in the composite outcome of all-cause mortality and emergence of drug-resistant bacteria at day 28 between the two groups. There was also not any difference between in terms of the four secondary outcomes or for the individual elements of the composite primary outcome in between the two groups. We did have previous meta-analysis which have reported a reduced mortality and increased clear, but as I said in the introduction, RCTs have shown inconsistent results, and some of them have been the patient population in the RCTs have been very heterogeneous to make any conclusions about what the results of the RCTs were. There were also pharmacokinetical kinetic studies which have shown us that quite intuitively continuous or prolonged infusions can achieve higher plasma and subacute concentrations. They can be used for resistant pathogens such as Acinetobacter and Pseudomonas, and they also deliver a greater exposure of the antibiotic to the target MIC. So these are all pharmacological studies which have been done, which have shown us that these are the things that can be achieved with continuous or prolonged infusions. But there have been some issues with the method of administration, which should take into factors such as the feasibility, whether it is that feasible to give the continuous infusion continued over 24 hours in an infusion pump. There have been issues with the stability of the drug, that is Meropenem, when it is given continuously over a period of 8 hours, thrice a day. And costs also might be an issue of maintaining the infusion pumps and the sterility with the continuous infusions going on for 24 hours. And there are logistical issues which we have already discussed. So the strengths of the trial was most importantly the target population, which was robust. Why I say that is because the target population had a microbiologically documented infection in 70% of the patients. And we had MIC values on those all microbiological, and the authors did provide us MIC values with all those microbiologically documented infections. And there was a rigorous adherence to the trial protocol and sending of the cultures. There were periodic sending of the cultures as well as cultures which could be sent by the treating physician as and when necessary, as per his or her discretion. There was also noted a high MIC in the identified pathogens, which made it a highly susceptible group, which could be susceptible to the emergence of a drug-resistant pathogens. And in that particular group, if you test whether it is continuous or intermittent, which is going to benefit, then that becomes a very robust target population. Also, most of these patients had hospital onset sepsis. And why I say that is because the median time from the onset of hospitalization to the inclusion in the trial were approximately 9 days. So it includes most of the patients who were hospital onset sepsis, who were more sicker, and they were at more risk of development of resistant pathogens. And if you see that can be displayed with the fact that the mortality in this group, in this group of patients, was approximately 31%, whereas previous studies have reported approximately 23% of mortality. So there was also a comprehensive subgroup analysis which was done to find any semblance of benefit which may be hypothesis generating for future studies, but unfortunately none of the subgroup analysis showed any benefit in either of the any benefit favoring any of the two groups. It was also the first largest RCT till date, which was a double-blind multinational and a very large trial. The limitations of this study included the fact that clinicians could change the dose of meropenem throughout the study period, and this was based on either kidney function or based on clinician decision. There were no strict protocols, although there was some guidance, which we've also already shown you in earlier in one of the slides, that there was guidance to the amount of duration that a particular organism could be treated with. But there were no strict protocols, and the clinicians could use their discretion if and when they wanted it. And remember that this is only the study has been done for meropenem. You can't extrapolate these findings to other beta-lactam antibiotics. Meropenem does have a little bit of post-antibiotic effects, and that ranges between zero point 0.7 to 2.5 hours, and for various organisms. And that's why you have to be careful when you try and extrapolate meropenem findings of this trial into other beta-lactam antibiotics. It might not really fit into the spectrum of other beta-lactam antibiotics, because every antibiotic is different with different post-antibiotic effects as well. And that might influence the study results to a lot of extent. Therapeutic drug monitoring is something which has not been done in this group of patients, and this is something which is there for the future. But unfortunately, due to the issues of logistics as well as the costs, this could not be done as per the authors. And this may be something that would have provided us with better idea about the drug concentrations that were achieved, and for the duration of time that the drug concentrations were kept above the MIC, as well as the interaction with the bacteria. And there was also one very important point of giving around 75% of patients who received concurrent antimicrobial therapy. That was very common. And that is approximately every third out of three out of four patients was on a concomitant antimicrobial therapy. And whether that antibiotic could have offered protection to the development of resistant bugs when these meropenem concentrations were low in the intermittent group of patients. And this is something which could not be explored again, because that was something which will always remain a confounder, because it might not be feasible, and it might be the clinician's decision to give a second antimicrobial drug along with the meropenem, and that confounder couldn't be eliminated. Plus the fact that whether the second drug which was given along with meropenem did actually achieve its therapeutic goals, and whether therapeutic drug monitoring also could have helped in that extent, that the second drug also we could know that whether it achieved its therapeutic targets and pharmacokinetic parameters needed for it to work properly. There was also something that could have been seen in the primary composite outcome, was whether there was microbiological cure or clinical cure after the starting of meropenem. They did see for the mortality, but mortality is a very hard endpoint, so probably a softer endpoint such as the time on the ventilator or the particular site, clearance of the infection from microbiological cure of the infection from the particular site, whether it be urine, blood, or the respiratory secretions. Any of this could have been used as a primary endpoint, which the authors didn't do that. And there have been problems with composite outcome because one of the outcomes might not be related to the other, and one might get influenced by a composite outcome as to one outcome showing benefit and the other not showing benefit, components of the outcome. And mortality benefit is something which usually you need approx 1200 to 1500 patients at least to be able to produce a decently powered trial, which can give you ideas about a mortality benefit. So then this trial had approx 600 patients. So really commenting about mortality benefit might not be the right way forward. So will this study change my current practice? So as of now, considering the evidence which is there available to us and the RCT which we are discussing now, this study won't change my practice. And why I say that is because this study showed equivocal results between the two groups. The continuous was as good as the intermittent group, and there was no real harm as well with the continuous group in terms of producing any toxicities or any other problems which could have come up. So considering that it is still a pharmacokinetically sound theory to keep giving infusions of meropenem, I would still continue giving continuous infusions of meropenem, which would last somewhere between 3 to 3 hours at least, and which may go up to 8 hours continuous infusions going all throughout the day for 24 hours. So at this point of time, we're still in wait and still in anticipation of the Bling 3 trial, which is basically a trial, multi-center randomized trial of continuous versus intermittent beta-lactam antibiotic infusions in critically ill patients with sepsis, and this might give us better answers to the other beta-lactam antibiotics as well, which are similar to meropenem with pharmacokinetics. So to conclude, in critically ill patients with sepsis, compared with intermittent administration, the continuous administration of meropenem did not improve the composite outcome of mortality and emergence of pan-drug resistant or extensively drug resistant bacteria at day 28. Thank you. See you soon.